Thank you, Mr. Chair. I think all of our panelists are here today. So I'm a former nurse, current physician, currently licensed, also 24-year military vet. I also practiced most recently in a community of 25,000 people. And I traveled 30 miles away to another community of 10,000 people to deliver care, in addition to making home visits, in addition to going and picking up people and driving them to my main office, in addition to driving them up to the University of Iowa so that they could get access to care. I've done academic medicine, small single specialty private practice. I've done military medicine, and I've been employed by a hospital physician. Which is why I was very proud to co-sponsor H.R. 2474, the Strengthening Medicare for Patients and Providers Act. And Dr. Furr, as you mentioned, this legislation would provide annual inflationary updates, and Dr. Pat, you also mentioned it, based on the Medicare Economic Index to physicians who support patients through Medicare Part B. I feel very strongly about this legislation exactly for the reasons you've said. And so I'm just going to ask a very simple question. Does your organization support this legislation, and how could family physicians benefit from an annual inflationary update?
I don't know any physician organization that does not support that.
Thank you. And I would have questions for all of you, believe me. Dr. Fielder, you stated that healthcare providers incur substantial cost to interact with insurers, likely totaling hundreds of billions of dollars per year, costs that are ultimately borne in large part by consumers and taxpayers. And I will say that I have done pre-authorization, step therapy, just about everything that I can to reduce the burden on physicians. How do you think physicians' responsibility to negotiate contracts, collect information about patients' insurance coverage, and battle insurers on prior authorization impact quality and access to care? And do you believe the burden is higher for doctors in rural areas than those who operate independent practices?
Right. So when we think about the ability of the payment system to encourage access to care, there's two sides to that equation. One side is the revenue side, but one side is the cost side of what does it actually cost to deliver that care. And so if we are imposing more on administrative costs, whether it be quality reporting or prior auth or other things, that means the payment rates are going to need to be higher to achieve the same level of access. In terms of what we might what we might do about that, I think there are, particularly in the context of Medicare, I think particularly the merit-based incentive payment system is a clear place to look. We are imposing very substantial costs, thousands of dollars, as Mr. Albanese said, per physician per year to comply with this program. And there's very little evidence, unfortunately, that it's having the intended effect of improving the quality or efficiency of care.
Well, thank you for leading me to my next question, Dr. Albanese. As you pointed out in your testimony, alternate payment models have not lived up to our expectations. Furthermore, APMs have been largely focused on primary care and provided little opportunity for meaningful specialist participation. Clinical data registries drive healthcare improvements by providing prompt feedback on quality performance and appropriate use metrics, including patient outcomes. They can help physicians monitor and manage patient populations, facilitating early interventions and preventive care, which can lead to more successful disease management and less expensive care. Incentivizing participation in this proactive quality patient improvement and feedback tool was a congressional priority when it was originally enacted in MACRA. Many specialties and subspecialties believe that as implemented by CMS, qualified clinical data registries are not being recognized to their fullest potential and are only being used as an option for reporting MIPS measures to CMS. And I truly wish CMS had stayed here for all of your testimony and answers to questions. Do you believe that CMS has done enough to fulfill congressional intent when it comes to the role of clinical data registries in improving healthcare?
So I would certainly agree that access to APMs and the APM bonus by extension has been uneven among different specialties and different geographic areas. With regards to MIPS, MIPS as well as many of the other quality programs across Medicare are very siloed and don't tend to take a comprehensive view of quality improvement. And the incremental steps that CMS has tried to announce in this space have been slow in terms of yielding progress. So I certainly think it's important to try and have more data availability that allows meaningful measures for patients to compare quality between doctors and providers without simply having government officials decide what their priorities are going to be at the expense of patients.
Thank you. And then Dr. Pat, really quickly, do you think Congress overpaying entities through the 340B program will contribute to the amount that Medicare beneficiaries will spend on premiums?
I do. I think the natural consequence of the $53.7 billion program last year being a reduction in costs is, while we think of it as a burden to manufacturers, if manufacturers are selling 30-ish% of their drugs at a 50% discount, that ultimately that leads to an increase in drug prices, which is a burden borne on the backs of American dollars.